Well, hello, sir.
Hey, is this thing on?
Hey, I'm pos-
Ban respirators in my house.
There you go. I
Delete that from the recording.
it started now. Good morning, everybody. This is being recorded. I don't know if you want to leave your video off or whatever, but I appreciate everyone being here. This is the early morning of 4 sessions on this Thursday. Nicola and Natasha actually did pop-up card making earlier this week, and this is part of the school's efforts to provide spring break programming. Some of it's light and enjoyable, like the pop-up cards, and some of it is, more serious, like, this conversation this morning from Nate about medical school during coronavirus. And some, cultural stuff, like in a couple hours, we have one about the Hunley. And then later this afternoon, we have a doctor from Ireland who actually went to College Charleston and is from Greece. And so that's at 4 o'clock. Nate, I don't know, you're super busy, but to the families who, a really different perspective on that, medicine in another country and how they're responding to it. So it's cool. But Nate, I'm turning it over to you. Thanks for doing this for all of us.
Awesome. Yeah. So to get started, I at some point might need to share my screen. Um, but really I'm not a huge
It's set to share whatever you want.
okay. I'm not necessarily a big slides guy, but I do have some slides for whenever we get there. I appreciate everybody for getting up this early. I know it's still later than school, but this is still about earlier than I've been getting up since all of this started. So for those of you who don't know me, I think most of you I've met either through swim team or through my work at the university school and the trips that you guys have taken down to the medical university. But my name's Nate Silvestri. I'm a third-year medical student now at the Medical University of South Carolina. And yeah, everything has kind of been turned upside down for me as well as you guys. So just to kind of begin, we have been doing online class as well. So I have a little bit of use of Zoom. We have a different software that we've been using at MUSC, but it has definitely been different. Just as an example, yesterday we had pediatric tumor board where every Wednesday through the whole year, about 25 doctors and a few students meet to talk about different cases, different patients, different scans, or different slides of cancer cells. And yesterday we had to do the whole thing on Zoom. And during a very, very serious conversation about what we were going to do with one patient, somebody's cell phone rang, and we found out that one of the doctors really likes Star Wars. So a lot of us are still learning how to work in this kind of digital classroom, but also workspace. But I think everybody's doing a pretty good job of trying to get there. For me personally, I basically sit at my laptop all day. It's been about 8 hours-ish a day of either patient care. So I get phone calls wired through my phone, and we'll talk about that in a second. Or basically just cases where they say Natasha is a 21-year-old female and she's presenting with X symptom or Y symptom. And I basically have to click through and take notes and take a test at the end. So even though I'm 25, almost 26 years old, I'm still in school and I'm still supposed to be learning. And yeah, I am frustrated. I think a lot of people are frustrated. I do think people probably miss their friends and miss being at school and miss recess and lunchtime, PE class, and everything else that's kind of the more social part of school rather than the sitting and learning part of school. I think for the first week, everybody treated it a little bit like a snow day. We didn't really have snow days here, but the 3 snow days I ever had, it seemed like that. We had a lot of fun doing a lot of nothing. I was outside every day in my backyard or on my dock or whatever. And now it's kind of ramped up to realize that to graduate on time and to meet the requirements that the government sets to ensure that I can become a doctor, I do have to do a lot of the work, knowing that chunks of my time as a clinical student is being taken away. And a lot of that time that I would be spending now is in direct patient care rather than as a book learner. We've kind of graduated from book learning to learning a little bit more in person and how to take care of people and patients as a whole. So it definitely does feel like I'm missing out on a bit of that time. Right now, I should be in Chapee, South Carolina, which is about 22 minutes northwest of Georgetown, working at the St. James Santee Family Rural Medical Health Clinic, which would have been a great time to do a lot of learning in the community. Unfortunately, coronavirus had a little something to say about that. So outside of that, and if there are no questions, I can go ahead and share my screen and just talk a little bit about what we were going to talk about today. Fortunately, Mr. Kroiner gave me like a wide bandwidth to talk about whatever I really wanted to talk about. I've changed it about 4 times, but we'll see what I'm going to go with today goes. Hopefully it's a little bit different. I don't know how much like call and response we can do on Zoom, or how much call and response you're comfortable, Mr. Kroiner. But I hope to have like a little bit involvement, even though it appears as though there's just the 3 of you guys. So hopefully we can make it a little bit fun. Maybe not as fun as pop-up card making. That obviously is a little bit heavier of a draw. So we'll see how this goes. And I'm going to go ahead and share my screen. Share. Oh, I have to open system preferences. So while this is going,
but I didn't mute myself. Has the South Carolina government said if they're going to do any relaxations or whatever for your requirements? Because they already said for like the teacher ed programs, like they waived like half the stuff I was required to do. So I know like some of the older med students, like where they have to graduate this year, what can they do?
Yeah. So for the older medical students, and just before I answer that question, it looks like, Mr. Kroiner, I'm going to have to quit Zoom to share my screen, and I don't know if that's worth it. I do have great slides, but it looks like I have to restart the program. Yeah, so for the older students, the 4th years, they're only going to miss about a month. So what they're going to end up doing is most of them have already completed most of their graduation requirements, and they're on electives. And many of them actually end up taking the last month of the year off anyway, in order to find a place to live where they're moving, to get a house or an apartment where they're going to live and set up their life in the new city they're moving to. So a lot of them are okay, and they've been able to turn their internship 101, which is 2 weeks of really hard training to try and make sure they're ready for the first day of their intern year in July 1st. So they're working on that. But most of them, they've been able to kind of relax the protocols, and any of them that have any time left, they've been working in telehealth to get their last clinical hours. For me, I'm missing kind of like the most important time of medical school. So 3rd year medical school, we have like 7 core classes that everybody in the country has to take in order to become a doctor and pass these courses. So they're internal medicine, OBGYN, family medicine, psychiatry, neurology, internal medicine, pediatrics, and that's it. That's 7. So we all have to pass those courses before we're able to move on to our 4th year of medical school. Now, what they're doing for us is they're giving us 3-week blocks of online learning, and then they're basically going to have us do 21 days straight in the hospital to make up for the 3 weeks that we're going to miss. And they're going to do it in blocks. So right now I'm doing 3 weeks of online family medicine. And then after that 3 weeks is up, I'm going to do 3 weeks of online OBGYN, which doesn't really help because a lot of that is very hands-on learning. But then I'll have 3 weeks of family medicine, actually doing family medicine, and 3 weeks of OBGYN doing labor and delivery, and benign gynecology and stuff like that. What is super interesting is how they're going to deal with that moving forward. So they're going to change some of our timing that we do stuff. So in July, I take my second boards exam. There's 3 board examinations that let you say you're a doctor. I'll take my second one in July. And then in August, I would be doing my sub internship where I'd be acting as an intern with a little bit more oversight from other doctors that are older than me. And then in August, I was actually planning on being at a different institution doing 1 month of pediatrics, which is what I plan on doing. Learning at a different hospital, almost like a tryout to see if they like me or not. Unfortunately, every medical school in the country has canceled those, at least until October. So what they're going to end up doing is pushing back all of my job interviews, pushing back all of my applications, because what they don't want to do is getting into the next round of coronavirus. If it does happen to come back, they would not have a workforce of interns that more or less get kind of the nitty gritty hospital stuff done from day to day. So they do want to kind of maintain their pipeline of doctors because otherwise they're 4,000 doctors short if they don't graduate everyone on time every year. So that's kind of what's happening. That being said, it doesn't feel like anything's been relaxed. I think it's all just kind of been put off, and some of my vacation time's just getting eaten up, which is kind of a bummer, but everybody has to sacrifice right now. So I don't feel that bad. I'm healthy and happy. So
Nate, I'm happy to pause it while you go restart so you can do these slides.
all right, it should take 2 seconds.
Back on.
Can you guys see the slides? Okay, perfect. Awesome. So sorry, I said that a few times. I've never had to share my screen before. Most of the meetings I'm in, I'm not the important person. So this is all very new to me. So COVID-19, what is it? What to do, why it matters. So a little bit about what I am doing right now. I guess I should probably present this view. A little bit about what I'm doing right now. As the first little bit shows, I'm bored in the house. I'm in the house board. That one was for the Turpacs and the TikTokers out there. Yes, I intentionally spelled TikTok wrong. I don't do that, but that's kind of how I feel right now. We talked about that. Still doing a lot of exercise and stuff, but not all of the same things I would normally be doing. So even though, again, that I'm a medical student, I'm still at home just like everybody else. A few of the things they are having us students do that is really cool is I'm part of a project that's doing screenings in the community. So right now, in order to get a coronavirus test, you have to be screened first. The reason being is that if you were to just test everybody, our test would have false positives. So some people would be testing positive, even though they don't have the disease. And that would be devastating to a health system. So you really have to have an idea to say, I think that that's coronavirus before we test it. So what we do is we direct everybody to online. There's an online screening that you can complete at musc.care. They would complete the screening, and then somebody would call them to say, hey, yes, you need to come in and get tested to one of our drive-up centers. No, you don't need to get tested. However, there are a few problems with that. One, not everybody has a computer. 2, not everybody that has a computer has internet. And 3, a lot of people have the internet and have a computer and have the internet and can do all those things, but can't figure out how to get to the right website. A lot of people are still more comfortable making a phone call. So right now we get a phone call that comes to MUSC that says, I think I have a cough and a fever. I need to get screened. They tell them once or twice to try and do it online. They can't. So then it comes through to my cell phone. So not right now, but a lot of time I sit with my cell phone open right here while I'm doing my work, waiting for it to ring, and eventually get directed to my cell phone in order to fill out this screening. So what I would do is I'd pick up the phone, and I'd fill out this paperwork that would say, Natasha T, when was her birth date? Most of them were born in the 30s, 40s, and 50s, people who aren't as used to the internet, what their address is, city, state, zip code, their phone number so that we can get a hold of them. Some people have been like, oh, can I give you my email? And kind of defeats the purpose. If you're checking your email, you should be able to turn in the online screening. Acknowledge that they live in the state of South Carolina, and then we move on. So when did your symptoms start? Do you have congestion or runny nose? Do you have a cough, sore throat? So 10 days ago, suddenly, and every time I answer one of these questions, more questions pop up. And this is kind of how you operate as a clinician. So if somebody says, yeah, I was really sick 3 weeks ago. Well, how do you feel right now? I feel fine. Well, you probably don't need to get screened for coronavirus. So that's something we don't need to worry about right now. It's important to know, but because of how stringent a lot of our limitations are on the ability to test everybody we need to test that's critically ill, we wouldn't want to screen that person at this time. So did they come on suddenly? Or has it been several days? Has it gotten worse and gotten better? Do you have congestion? Because that's one of the symptoms. Have you had a cough? That's definitely one of the symptoms. Do you have a runny nose or a sore throat? What color is your mucus? So which one of these? How often do you cough? Because some people say I have a cough and it's really, they've coughed like once today. And some people have a cough and they're constantly coughing. And those would be kind of different thoughts and different diseases. And as you kind of think in your head, like, oh, that maybe sounds like the flu or coronavirus, or, hey, I think you just probably have some allergies, which is the other day I woke up and my nose was really clogged up and I haven't been able to talk right. And my sister's been running around the house telling me that I have coronavirus. I haven't left the house in weeks, so I don't think I have the coronavirus. I think I probably have a little runny nose from the pollen. So does the cough bother them at night? A lot of these questions keep going, keep going, keep going. And eventually I should start answering no. So it keeps giving me, are you able to take your temperature? What's the patient's temperature? So if you don't have a fever, you likely don't have coronavirus. How long have you had that fever? Are you having difficulty breathing? And you keep going, answering these. Do you have asthma? Like, because we would want to test people who have asthma at a lower suspicion than if we didn't, because if we can catch somebody who has this virus earlier, we'd be able to treat them better. Do you have pain or pressure? And this kind of keeps going down to try and elucidate whether or not they have coronavirus. Have you been in contact with the flu? Could it just be the flu? Are you any of these close contacts? So we really want to be testing people who are in close contact with young children, pregnant women, older folks, and people with asthma, heart disease, et cetera. Have you been traveling internationally? So have you gone somewhere that there's been a lot of coronavirus? Have you been in Italy? Have you been in Spain in the last 2 weeks? So a lot of these are things we think about, whether it be this or whether it be back during the Ebola epidemic. Some people would sneeze and blood would come out and they'd come to the doctor and say, I think I have Ebola. Well, have you been to Africa in the last 2 weeks? No, I've just been here in South Carolina. Well, you probably don't have Ebola. We need to figure out why you're having blood coming out of your nose when you sneeze, but it's probably not a hemorrhagic fever. So all of these are things you think about as a clinician. And you would keep going. Have you been in contact with somebody who has coronavirus? Yes or no? I'm going to just say no, no. Do you live with a healthcare worker? So I do live with a healthcare worker, my dad, and I talk to him about this every day. And really, he is at an increased risk for getting the coronavirus because he is in contact with patients who have the coronavirus. So that would make a clinician think that maybe they do, maybe they don't have the coronavirus, more so. And you keep going, and eventually you list all of their medications. You would list their weight. So are they obese or are they not? And then eventually you would submit it. And once we submit it, that would go to a provider who would be able to use the algorithm that is given to them to be able to call that person back. And it's super, super important that we get people that phone number to call us. So I just want to kind of run you guys through that really quick, just to show you that, even though I'm not in care of patients, I can still sit on a 30-minute phone call and see if they need to get tested or if they don't. And that saves clinicians time. It gets people who maybe not be able to operate the internet able to get in contact with the health system. And hopefully it would save lives in the future. My phone has rung twice from it. I've only worked about 8 hours, and there's a bunch of us sitting in a call pool. And so you really just have to be quick to the phone to answer it. So sometimes I let it ring if I'm super busy, and somebody else in my group will pick it up. And then sometimes I just hop right on, talk with a little old lady from Kershaw County or wherever, Charleston County. So the other thing we're working on, this is more of a student-run project that I think is really, really neat. It's the Community Vulnerability Project. So this was something that was dreamed up by one of my friends, Alan Snyder. He's a fourth-year medical student, and he was bored out of his skull, and he thought, well, there's a lot of, he's been, on Instagram and Facebook seeing a bunch of facts about coronavirus that aren't true. Some of them saying that there's a conspiracy that 5G internet is causing the coronavirus, that coronavirus, you can't get it if you're healthy, and a bunch of different false things that are floating around the internet right now. So what he decided to do was say, hey, how can I get in touch with people who may be vulnerable to give them proper information from a medical person about how they can protect themselves, what they can do to try and prevent the disease to getting them. So what he did was he asked MUSC, how many patients do you guys have? So he found out there are 3 million patients in the MUSC bubble. And what he decided to do was say, hey, can you just give me phone numbers for everybody who's 85 and older? So we got a list of phone numbers, say 85 and older. And so one by one, starting tomorrow, we're going to start calling every person who's been to MUSC who's 85 years and older. And basically just say, have you heard about coronavirus? What are you trying to do? What's your understanding? What do you think you can do to try and prevent coronavirus? And all of this was kind of based on a vulnerability map that I'm going to show you guys here. So this is the map that they made of South Carolina to find the communities most heavily vulnerable to coronavirus. And this is kind of going to bump into our next little piece of discussion. So these vulnerabilities were based on computer learning and artificial intelligence to say, okay, we know that coronavirus can happen in lower socioeconomic communities. How can we predict which communities are going to be the most heavily impacted? So if I scroll over whichever county this is here, if I scroll over a chunk of Charleston County, our community vulnerability is low. The reason being, is there's a very large group of healthcare providers here, but that doesn't mean that there aren't vulnerable communities. And then if you go ahead and click on Colleton County, you can see that there's an extremely high vulnerability. So we're going to be able to contact patients in Colleton County to be able to talk to them about coronavirus. And we're going to talk about this thing over here that says socioeconomic influencers, and be able to say that reasons why some communities rather than others would be able to be protected or impacted based on how they live, where they live, and their access to medicine. So that's super interesting. And the idea would be that we would be able to contact these people and this brief 5-minute discussion about what coronavirus is, what these, what we can tell them to do, cover their mouth, don't go out, try and find somebody else to get your groceries, et cetera. We'll be able to protect these patients from end up having to go into the hospital. And it's just another way that MUSC students can help flatten the curve. So I know that a lot of people, if you want to unmute yourselves, whatever, I'm going to start asking a few questions. I know you guys have had some really interesting talks. So if anybody wants to talk a little bit about what you understand and what you know about coronavirus right now, that'd be awesome. So how does it spread? Anybody? Mr.
It
Coroner?
spreads on surfaces.
What was that, Katie?
It spreads on surfaces and through people's coughs.
Very good. Very good. So it spreads via respiratory droplets. So it absolutely does spread like that. Do you know what part of your body it kind of affects the most?
It affects your lungs the most, doesn't it?
Yeah, very good. Very good.
I've been
Awesome.
hearing a lot that people that do get it, it weakens their lungs. So even after they are healed, it's like they're not sick anymore. Like their lung capacity isn't the same.
Yeah, so that has happened to some people. A lot of people come all the way back to normal. And some people, unfortunately, don't come all the way quite back to normal, but maybe 95% of what they used to be. But yes, it absolutely does affect your lungs. And last question while you're on the hot seat is, why is that so important? Like, why does the infection affecting your lungs, why does that cause us problems?
Because there's so many, to be able to like get up and do and like go do things that you need every day, you need to be able to breathe. And if you can't breathe.
Awesome. Yeah. If you can't breathe and you can't put oxygen in your blood to your cells, you absolutely can't get up or do anything. And that's why a lot of people have been so sick. So that's awesome, Katie. Thank you so much for A, being here, and B, being our Gold Star student of the day. So awesome. Thank you. So there are a bunch of different names for coronavirus: COVID-19, SARS-CoV-2, coronavirus. What is it? What is it not? So it's not the end of the world. I've seen a lot of really horrible things on the internet, and my friends saying that it's going to be the end of everything because everybody's cooped up and on the internet. It's a virus that attacks your respiratory tract, that Katie told us. It spreads via droplets. So if you cough, if you pick your nose, if you lick your fingers, and then touch a surface. And just a few other facts that I find super interesting. And Katie, you can take these and tell all of your friends about it. So why is it so contagious and dangerous? It's because it's new. Your body and our immunity as an entire society is based on what infections you've had in the past. So all the way back when explorers first came to the United States in the 14 and 1500s, there was a whole continent that they found that was inhabited by Native Americans. And they brought diseases from the old world to this new world that essentially wiped out a large portion of the Native American population. It's not because it was any more dangerous or a worse virus than it had been in England and Spain and Europe. It's because the population here in the Americas was not used to that type of infection. So that's why it's been so dangerous and scary, because we don't have the immune response or now the vaccines that we've been given our entire life to help protect us. So one thing we talk about when we talk about viruses is the R naught or the R0. And that means for every one person who were to get the virus, how many people would they give that to? So for this virus, it's about 2.2, which means every one person that gets it would give it to about 2.2 people. And I know you can't have 2.2 people, but I'm sure everybody's taken a math class and gets averages. So that's how we kind of come to that number. That's compared to the seasonal flu, which is what we get the flu shot for. So you would only give that to 1.2 other people. So usually the seasonal flu kind of stays about right where it's going to be every year, except for when we have different ones. So the swine flu, which was the pig flu that happened in the early 2000 teens, was about 1.5. And that's because it was a little different than what we had been used to. Now, measles, which we remember was a huge outbreak and used to cause a lot of sickness back in the day, and in Brooklyn this year, affects about 12 to 18 people per every one person. So it's a little bit different. So that's why it's been spreading so rapidly through the world, is because it doubles every time it infects one person. And that's why it's so important to stay at home and stay away from people. Not for your health. Most of the time, all of us on this call would end up being very healthy, but for the other people that would get sick around you. So one thing I thought maybe you hadn't covered is, where did it come from? So this little guy is a horseshoe bat in the tiny little corner over here. And there are billions and billions of bats around the world, and thousands of species here in the United States and across the world. And it's actually become known that bats are a huge carrier of viruses, which is crazy. You would think that, well, they have coronaviruses in their system. Why aren't they getting sick? And what's fascinating is that bats are the only mammals that fly. Not even regularly fly. They're the only mammals that fly. And in order to fly, they actually have to ramp up their metabolism. So just like when we run and get hot, the same thing happens for bats. So these bats are flying and get super hot. Their temperatures go above 100 degrees and their heart rate goes above 1,000. So even when some of us run, our heart rates maybe go to the 180s, 190s. And that's if you're in pretty good shape. These bats go into the thousands. So they're able to have these viruses, and the viruses live inside of them, but they're not able to replicate because they get so hot, much hotter than a human. So bats will regularly get to 104 degrees. So they're comfortable with a little bit of a fever. Whereas if you or I or Mr. Kreutner had an 104 degree fever, we would be on our couches, really sick or in the hospital. And bats also have this very interesting part of their immune system. So when we get sick, our bodies intentionally give ourselves a fever. And because we're given that fever, that's what we use to try and kill the cells that have the virus inside of them. So bats actually don't have that in their immune system. So they're able to harbor a bunch of different viruses without ever getting sick. And fun fact, I learned this morning, that bats can live to 30 years old. Who knew? So those are all little bat fun facts that you can bring home and share at the dinner table tonight. But they also carry a lot of other viruses like rabies and Ebola. And they think that these viruses may be jumped from a bat to a different carrier. In our case, maybe a pangolin, which is like a small animal in China. Whereas the Ebola virus jumped from a bat to likely a primate or a monkey. And the SARS virus, the respiratory virus that you've heard about on the news, maybe jumped from or the MERS virus, the Middle East Respiratory Syndrome, jumped from a bat to a camel, and likely somebody ate that camel's meat. So that's how the virus kind of moves around without really killing these bats. I thought that was kind of neat. So I figured I'd share that. So moving on. What is the impact of the coronavirus? So no school, obviously. And why is there no school? Because that 2.2 number we were talking about earlier. So it's really important that you don't give the virus to somebody else if you get it. So if you stay home with your nuclear family, your mom, dad, grandma, whoever lives in the house with you, hopefully you wouldn't spread any virus that you had outside of your house to get other people sick. I'm sure you guys have all learned that. But one thing I think is really important that people don't talk about enough is that what stops the virus from spreading is the physical distance that you put between yourself and another person, not the social distancing. So I heard a really interesting sociologist talk about in 1995, there was a big heat wave in Chicago. And a lot of people that passed away because it was so hot out were older people. And what saved their lives were them being able to contact a loved one by phone or somebody stopping by to just check on them. So it's really important to remember that we live in a digital age where we can have these Zoom meetings and we can FaceTime our friends or call somebody on the phone. And that means that you're socially close to somebody. You can check on a loved one. You can call your grandma. You can FaceTime your grandma if your grandma knows how to operate FaceTime. Mine definitely never knew how. But if yours knew how, that'd be awesome. And you can have a tea party with your grandma or do whatever you want to do with these older folks without putting them in harm's way by being physically close to them. So I just like to remind everybody, and I tell all my friends at school that physical distancing is not social distancing. So I wish people would use this a little bit more and remember that we can all be a huge community without physically being close to one another. I do know it's super frustrating to not be around your friends or family, but it's a sacrifice everybody is making to try and flatten this curve. So the last thing I really wanted to talk about quickly, because I didn't think this was covered by any of your other speakers this month or this week, was the healthcare disparities and the differences different communities have in the impact of the virus. So a lot of what we talk about when we're talking about trying to protect people in general is their morbidity and mortality. Their morbidity meaning what sicknesses do you have? So do you get a bunch of ear infections? Did you have a heart attack? Do you have high cholesterol that could make you have a heart attack in the future? And what Dr. Anthony Fauci, the head of infectious disease for our country, who's been running kind of the coronavirus task force, has been talking about is how different communities around our country have been impacted in different ways. So Katie, since you talked about this earlier, or since you were participating earlier, what is it that you guys are doing tomorrow that, or that the university school as a community, and Mr. Kroner, you can jump in. What are you guys doing tomorrow?
Oh, so Nate, Katie's at senior at Wanda going to Clemson this fall to do biology.
Oh, very cool.
I know.
Very awesome.
So
Mr. Kroner, what are you guys doing tomorrow?
So we're friends with schools for years, and in February, when you could see this was going to get bad, we told a couple schools in North Charleston that we would be there for them during this crisis, because you could tell people would tighten up and people would really be in need. And one of the things that public schools across this country do well is feed children who don't have the resources in their homes always to have food so they can learn. So every week we gather toys and books and food, and then we go to sites at these schools that we're friends with where families will be picking up food and distribute stuff. So we're going out to Ladson Elementary, and then we can't actually go on the school sites currently. We can go at the drop-off point. So we're going to a apartment complex off Stall Road 2 to hit Pinehurst and Midland Park and Northwood and Stall High School. And then hopefully one more site tomorrow. It depends on how many goods we've gathered this week. It's been hard because it's spring break. That was a lot, sorry.
No, that's great. And that kind of ties in exactly what we're about to talk about. So I think everybody realizes with that the communities that are being affected are communities that have lower socioeconomic status or a lower income base per their community. So for people like that, epidemics like this and healthcare problems in general affect populations worse or better, kind of depending on their economic baseline. So Katie, can you think of a few ways, by closing your eyes and pretending I didn't open this slide that has all the answers on it, reasons why one community or another may be more impacted or less impacted by the coronavirus?
I know for me and my sister, it's kind of hard to learn in like a different environment. Um, our school was handing out things like laptops and computers and stuff to those kids who don't have access to those things to do all of this online learning. And they, the library as well as the schools have their internet range expanded so that students can go and sit in the parking lot and do homework there. So there's educational, then some people don't have, and then there's like a money thing.
Yeah, Katie, that's great. So a health disparity specifically is defined as differences in illness and injury and disability or mortality or death between groups. So for reasons exactly like Katie just mentioned, certain places have less of an access to education. So if you don't have internet, you couldn't Google how coronavirus would help, or more importantly, why should I take my blood pressure medication, or what is high blood pressure, or what foods am I eating that cause me to have high blood pressure or high cholesterol. And a lot of those factors arise in different communities. So if you don't have a lot of money or you're experiencing poverty, you are more likely to eat cheaper fast foods. And because you've been eating cheaper fast foods for the last few years, you may have high blood pressure or higher rates of diabetes. There may be environmental threats. So if you live in a dangerous neighborhood, the stress of living in a dangerous neighborhood can weaken your immune system and leave you to getting sick easier than people who live comfortably in a safe neighborhood with a roof over their heads. Some people don't have adequate access to the healthcare system. So we live in Mount Pleasant, where there is a bunch of hospitals within a 10, 20-minute drive of where you live. And a lot of us have cars. So if you have a car, you can just drive to the hospital to see your doctor. But for some of my patients, they have to get 1, 2, or 3 different CARTA buses in order to come see us. Or they have to get a ride from a loved one, and maybe that loved one is busy that day and they're going to miss their appointment. There's education inequity. So this public school system in Mount Pleasant is fantastic, one of the best in the world. And there are private school options for those that have the means. But in a lot of communities, they don't have the same educational resources. So they're not learning about, how do I take care of myself? How can I make sure I'm a good enough reader so that I can read the back of these nutrition labels? Can I do the math that says how many calories am I eating a day? A lot of those are not very easy, even for me, and I've received a lot of education. So imagine being a patient in a community that doesn't have that type of education. There are also individual and behavioral factors that affect that as well. So that's a health disparity that impacts communities, whether it be African-American or rural, urban. These are all different communities. And then there are health care disparities. And those are the differences in groups. So African-American versus Caucasian versus Latino, Asian, old versus young. Those are different groups. But this is healthcare disparities or differences in insurance coverage, access to care, and the quality of care. So imagine if you are somebody who has access to care, but the quality of that care is not very great. That's a huge problem. Maybe you have access and you have access to quality healthcare, but you don't have health insurance. If you don't have health insurance, a lot of what we do in medicine is super expensive, leaving you to seek other options, trying to take care of your blood pressure at home, not being able to see a doctor about something urgent when you need it, being afraid to access the medical system because you're worried about the bill can make the bill down the road even worse. So a lot of these are healthcare disparities. And then there are social determinants of health, just like we talked about earlier. So do you have a job? Are you employed? Do you have housing and transportation? Is it safe to walk in your neighborhood? A lot of these are social determinants of health, things that are outside of a person's control that determine their health outcomes. So we know that if you live in a dangerous neighborhood and don't have access to quality green space and able to exercise, you're more likely to have obesity, which leads to a lot of different problems. Even more interesting, I did a project a few years ago that it literally was the zip code you were born in that was the most determining thing in your health, in your overall health. Just based on the zip code you were born in, we could predict that certain zip codes had up to 8 to 10 years difference life expectancy, just based on where you were born. That wasn't based on your underlying health, medical conditions, or anything else, just based on zip code. So that's something to think about. While you may think that staying at home is a burden to you, it's trying to keep these other communities from getting ill, especially when they have higher rates of hypertension, diabetes, that get them much more sick than people in our community may be. So one last thing that was absolutely jarring when I saw this on the news the other day, and I thought it was really important to talk about, because a lot of people actually don't learn about disparities and don't learn about different communities. And while the university school and Wando have probably been very good about teaching you these things, I find it super important to just remember that how fortunate we are, that we are all sitting in our homes or at an office with internet, and currently safe from coronavirus. So right now in Illinois, 43% of people who have died and 28% of the positive tests were African-American individuals, which is wildly interesting considering that nearly half of their deaths came from African-Americans, who only represent 15% of the population. In Chicago, more than half of the deaths were African-American. And before coronavirus started, Chicago African-Americans lived 8.8 years shorter than white Chicagoans. All of that is to say that the African-American community in Illinois and Chicago, and even in Louisiana as you move down, are more likely to pass away from this disease. The question is that a problem of their health or their health care? So we've discussed this earlier. African-Americans across the United States have a higher level of health disparities that lead to worse outcomes. So some of the social determinants of health is that African-Americans who are affected by the coronavirus layoffs and unemployment work in industries that are more likely to be impacted. So food and beverage, service industries are worked at a higher rate by African-Americans and people of color than of white individuals in this country. And that means that they're more likely to be laid off right now, which means they're less likely to pay their bills or be able to see their doctor or pay for their medications, which also means they're less likely to be able to seek treatment for coronavirus. Right now in South Carolina, it is free to get screened. It is not free to get tested, and it is certainly not free to be sick in the hospital with coronavirus. So if you don't have insurance and you don't know how much the test itself is going to cost, people are more likely to stay at home, and their illness is more likely to progress to a point of possibly death, just because they don't have the money to pay for the health care that they rightly need and deserve, which I think is a huge problem in a country that's supposed to be the greatest country on the planet. African-American people, as we talked about earlier, are more likely to have higher rates of hypertension, which is high blood pressure, or diabetes. And because of that, they're more likely to be affected by these illnesses, by coronavirus specifically, than people who are white or Asian. So as above, 70% of the deaths in Louisiana have been in African-American populations because, as we've talked about, and I'm sure you've heard from a lot of other people this week, underlying medical conditions such as high blood pressure, high cholesterol, diabetes, heart disease, lung disease, all of them are more predominant in communities of color rather than in white individuals. And even more scary or terrifying, as I put right here, there are healthcare disparities that were shown by a recent study in Massachusetts that doctors were less likely to refer African-American patients with the same symptoms for coronavirus testing. So while we can sit down and say, well, it's because they have these health disparities and we need to attack these health disparities, there are physical healthcare reasons why African-Americans are doing less well or having poorer outcomes than their white counterparts right now. And that's because there's a bias against African-American people in a few of these studies that show that they're less likely to be tested for the same symptoms. So they still have the headache, the fever, the cough, the muscle aches. They're more likely to be told by their doctor who they went to seek out that they had the flu or something else to explain their symptoms rather than to get coronavirus testing, which means that with the same symptoms, they're less likely to test. They're more likely to go home, continue to deteriorate from a health perspective, and end up back in the hospital or worse. So again, the reason why I bring this up is because this is a problem that was happening before coronavirus. It is a problem that will continue to happen after coronavirus. And I think is one of the biggest things that we face in our country as we move forward voting, or we move forward to be leaders in our community, is to always remember that there are people out there who, while you can go to your doctor and be taken care of well and have your parents' health insurance, like I still do, pay for most of your health care, and be raised in a household that is close to a grocery store or a farmer's market to get fresh fruit and vegetables, to know that because of where I was born and the family I was born into, I have less of a chance of getting high blood pressure, diabetes, and more of a chance of eating healthy and being able to exercise outside. And knowing that if you go out right now and infect the 2.2 people that could have that if you had coronavirus and you were to infect 2.2 people, those people could eventually be people in a community that aren't able to react and treat the coronavirus as well as they can in your current community in Mount Pleasant. And even more interesting is that right now they found out that African-American folks and people in the service industry are still working in these critical jobs, but are working for less pay. So they're out driving trucks and moving food and stocking shelves and putting themselves at risk to get a disease that they're not equally equipped to combat from a health standpoint and from a community health standpoint. So what is the effect of the coronavirus on healthcare in closing? Right now, the hospital's closed. I'm not there, and there are no secretaries. Non-essential surgeries have been stopped. So 75% of the surgeries have been cut, and those are what pay for the hospital continue operating. And up to 80% of MUSC is now operating on telehealth, which all of that's great. It keeps people home, but it doesn't pay the bills. So 15 to 20% pay cuts are happening for everybody at MUSC currently fighting the coronavirus, that are not the actual doctors and nurses on the front lines. So it is really important to stay home. It is really important to continue flattening the curve. And one other thing I thought about, my dad came home the other day and he's a doctor. And I said, Dad, what's like the worst part of like being in the hospital right now? Cause I can't be there and I wish I was. And he said that he couldn't hug his patients that are super sick or have cancer or are dying. Limiting the contact with patients is devastating for a doctor. We survive on physical contact with people. You contact somebody to touch their abdomen or feel their abdomen to see if they're sick, or listen to their heart with your stethoscope. And a lot of that's being limited right now. And I think that that's one of the most devastating things I can think of, is not being able to hug a patient or a family member and say, we're doing our best. We hope it's going to be okay. And that, I think, is really challenging. And the last thing is, I've heard a few stories of loved ones not being able to be in the hospital. So they're getting FaceTime by friends and family. They're FaceTiming friends and family. So nurses are FaceTiming people so that they can talk to their loved ones or whisper some words of encouragement in their last moments or while they're sick in the ICU. So I think all in all, what I'm really trying to say here is stay home. Don't go out and play with your friends in the neighborhood. I know it can be really hard to think like, well, my boyfriend or my girlfriend or my My best friend wants to go play tennis, and that seems fine. It's sort of distant. At the end of the day, it's other people that are going to get sick and be less well off than those of us that are currently on this call. So remember, you're staying home for other people. And I thought it was really cool. I saw in the news last night that Governor Cuomo in New York has the hashtag stay home for. Like, who are you staying home for? And for me, I think I'm staying home for all the people I talked about and all my former patients and current patients that I discussed earlier. Whereas I think a lot of other people would stay home for their grandparents or their aunts and uncles, or their friend that has cancer or their friend that has diabetes. So think about who you're staying home for, and remember that it's physical distance, that not social distance, that really can help us combat this disease. Because at the end of the day, we all have to remember that we are a community and a digital community, and we can all stay in contact with one another moving forward to make sure that we get through this together and not as a bunch of different states or a bunch of different communities, but as one United States of America and one globe and one humanity. So I think all of that's really important. I know I've gone over time. I'm really sorry about that, Katie and Natasha and Mr. Kreiner. But if you guys have any questions, feel free to call or text me or contact me via my email. I do, again, as I said, sit still for most of the day waiting for my phone to ring. So thank you guys for listening to my TED Talk. And I really appreciate you guys for waking up this early. I forgot that you guys can't see my face right now, but I was waving. So if anybody has any questions, now's a great time. If not, feel free to reach out to me at my email. I'm pretty good about it.
Yeah, I just want to say thanks. This was, it was really powerful and giving us the window into your perspective to allow us to see inside the healthcare community, their view, and then also being frank about your feelings about the stuff that maybe this will be a launching point into, like you were saying, ways we can improve our country and our healthcare system and all that stuff. So thank you for your being up this morning and for putting this together for us.
Absolutely. I don't know how to unshare my screen to see you guys, but yeah, absolutely. That's what I'm here for. I don't know how to get rid of this.
I'm working on it. Well, we'll figure it out later. But thank you. Everyone, have a great day. Nate,
Yeah.
I'll catch up with you later.
See you guys. Thank you so much. Have a great day. Keep learning. Enjoy the Hunley.